Hello, welcome everybody. As you're popping into this meeting, we have a lot of attendees today, so it's going to take a minute for folks to get in from the waiting room, and we appreciate your patience as we start just a little bit later than planned. I think we currently have about 500 people on waiting to get in, so just give me a second, and I will welcome you formally. All right, those numbers are still ticking up, but we are over our 500 that I saw. Let's get rolling. My name is Matt Shepard. I want to welcome everyone today to this presentation on Medicare home health and DME updates. I will be moderating, and we are pleased to present this in partnership with the Christopher and Dana Reeve Foundation. Our presenters today are going to include Center for Medicare Advocacy Senior Attorney Wey-Wey Kwok, Supervising Attorney Eric Krupa, Attorney Christine Huberty, and we are also pleased to be joined today by attorney and disability advocate Sheri Denkensohn of Happy on Wheels and Reeve Foundation Public Policy Manager Angel Heinz, who's going to tell us more about the foundation and their mission in a moment. The Center for Medicare Advocacy, on the next slide, as probably many of our attendees know, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage, health equity, and quality health care for older people and people with disabilities by providing exceptional legal analysis, education, and advocacy. Now, a little bit of housekeeping before we begin in earnest. Manual closed captioning is available today, courtesy of the Christopher and Dana Reeve Foundation. And as you can see, so is sign language interpretation. You can change your view of presenters and slideshow by using the view controls at the top of the Zoom window. I'm sure some people are familiar with that. Attendees, of which, as I noted, we have a whole lot today, will be muted, but we do welcome written questions as well as live when we stop. So feel free while we're presenting to drop a sentence or two on what you'd like to discuss in the questions panel that you can see down at the bottom of your control panel. And I can pass those on to our presenters when we stop. Please also note that we have the regular old chat like every Zoom call, and drop your name in there and tell us where you're from, and we'd be happy to say hi to you. The agenda for today, as you can see on your screen, is as follows. You're listening to me right now, and then I'll pass it over to Angel to introduce things and get us going in earnest. Whoops. I was going to go through the rest of the agenda. We'll go through our durable Medicare equipment overview as Angel introduces Sheri from Happy on Wheels, and we'll bring up Eric Krupa, supervising attorney here at CMA. And then we will have our home health coverage interview with Christine and Wey-Wey from CMA, after which we can finally get to our questions and discussion. So enough from me. Let me hand things over to Reeve Foundation Public Policy Manager, Angel Heinz, to really get us going. Angel, thank you.
Thank you so much, Matt, and thank you to all. It looks like 700 of you that have joined in today. We're so delighted to co-sponsor this very important program with CMA. So to introduce myself, I'm Angel Heinz, and just to give a visual description for those that need one, I am a African-American woman with brown skin. My hair is pulled back in a bun today, and I am wearing a green dress. Um, so, um, our mission at the Christopher and Dana Reeve Foundation is we are dedicated to curing spinal cord injury by advancing innovative research and improving the quality of life for individuals and families impacted by paralysis. Oh, the Reeve Foundation, I just want to give you a little bit of background about the Reeve Foundation before we head into our panel. We have been fortunate to operate the National Paralysis Resource Center for over 20 years. We are the only federally funded entity dedicated to providing direct services to the paralysis community. We hope that many of you in attendance today have been able to reach out and contact us for those services, but I thought I'd just give you a reminder and some brief background of what we provide, some of the services that we provide. Next slide. So this gives a great overview of the services that we provide at the Reeve Foundation. The PRC, the Paralysis Resource Center, it promotes the health and independence of people living with paralysis, spinal cord injury, other mobility impairments, and those loved ones and family caregivers that support them. We provide this free, comprehensive, personalized information and resources, referral services to help those who live with paralysis achieve their most independent lives. So to quickly highlight a few of the functions, our information specialists, these are our front of line staff. This is the first person that someone may reach out to sometimes after injury or accident, or if they're in crisis, or it may be someone who's lived with paralysis for years and has a new question or just needs support on a specific issue. Where thanks to congressional support, we've been able to have someone available on the phones for those times of need. We also have our military and veterans program, which is staffed by military veterans who have that experience on the focused need of active duty military and veterans living with paralysis. And this includes direct support, peer mentor support, and just helping to navigate the sometimes complicated VA-specific issues. And we also direct funds to nonprofit organizations nationwide to help be on the ground in communities and help individuals impacted paralysis. So that is a brief overview. But one thing I just wanted to share before we get on to the panel today is that we need your help. We really need your help, and we would love for everyone on this call, when it's over, to take action. Unfortunately, the president's budget that was released on May 30th calls for the complete elimination of the Paralysis Resource Center, along with some other vital programs that serve people living with disabilities. If this is adopted, it'll dismantle all of the work that I just talked about, and these are vital to lives of the people and their families that live with paralysis. So we really need you to take action and to contact your legislators and tell them to not abandon us, that please to support the paralysis and the disability community. There's a QR code there. And after the panel, we can bring the slide back up for you to get more information, or you can reach out to me at the Reeve Foundation, myself, or our grassroots advocacy manager, Gerard Arnhem, to help you help us. We really appreciate the support. So now I will turn things over to one of my favorite advocates, Sheri, to start the conversation on Medicare coverage of DME.
Thank you, Angel, and welcome to everyone from all over the country. There's quite a group out there. So I'm just going to dive right in, basically, because you are going to hear much of what I have to say from our next presenter in more detailed terms. But here's the deal. I'm complex. I use a complex wheelchair. I have a trach, I have a colostomy, I have a urostomy, and I am also a breast cancer survivor. So I'm going to use some terms today that can be used in multiple ways. I'm going to try to use them as best they can. But I'm new to this game. So just like everyone else, CMA, Paralysis Resource Center, SHIPS, there are critical people involved. If you don't remember anything from my presentation today, remember that you need to do your research. You need to know that you need to be a first-class coordinator. A crown will go on your head, and you need to be ready to have grit and fight. So first of all, with all of my complexities, I had to use my boxing gloves because I can't kickbox. Bottom line, you need to do the math. So I was a federal employee. I did not retire with Medicare. I wanted to keep my Blue Cross Blue Shield because I wasn't sure it would cover everything. Then I decided later, for cost saving purposes, most recently that I wanted Medicare Part B, primary, and my Blue Cross secondary, and a different Blue Cross. The open seasons, or the open enrollments, as they're called in different programs, did not gel. So you need to know that. You may at some point have your open season if you have your employer coverage or federal coverage. And if you're not just doing Medicare B, which is its open enrollment from January to March, that you may have a gap where you're only covered by one. Make sure you know that. In addition, you should be preparing in advance. I have a lot of supplies. I have colostomy supplies. I have urostomy supplies. I have trach supplies. I have supplies for my trach catheter that's motorized. Supplies that go with my trach. What is covered? How many are covered? What can you use? And does that gel with what you do every day? For instance, with me, I had to completely change my colostomy system. I had to decide what I wanted to use. Luckily, the entities, the names of the companies, which you might know, but only if you're in the business, you know them well, Hollister, Convatec. They're great at providing you with samples, so I could try certain things and make a decision. But in the end, there was a lot of change. So that's a very, very, very important part of the of what's involved here. And I will also just talk a little bit about the wheelchair, even though that could be its own presentation in itself. Many times when you get a wheelchair, it's called durable medical equipment, just like the supplies I talked about, even though people think of them as supplies, they're DME, even though they're soft and not very fuzzy, but their utilization. Lots of things that you use. The wheelchair is your means of getting around, and it is not an easy road to climb. It is often that you need to go to a seating clinic if you're getting a brand new chair, or if you're getting parts, then there's repairs involved. Again, certificates of medical necessity. Why do you need it? Who writes it? What's written? Crossing every I and dotting every T. I'll get more documentation in a minute as to what I'm facing. Now, let's talk about physicians. Number one question, do they take Medicare? Well, you need to know. Your physician may not. And when it comes to physicians, your primary care doctor may not be able to write the documentation for everything you need. You may not see them regularly. For instance, I needed catheters. However, I had not seen my urologist in over a year. I have to see my urologist because I can get catheters, which meant I had to buy them out of pocket. Try to make your appointments as earlier as you can. Hope that your doctor understands the system. Hope that it's done timely. And then once again, your coordinator crown goes on. Most importantly, documentation. Like I said, it has to be done right. And there is a formula. There's no checklists out there. I wish there was. It's a call out for checklists. There are people to help you like CMA, the Process Resource Center, which we hope will continue, the SHIPs. But it really a lot comes down to you, because you know yourself. And being a self-advocate is really, really important. So know that you're going to have to be the one making sure that whoever needs to write what they need to write gets the right information correctly, that you see who you need to see, that you talk to whoever is providing the equipment or the wheelchair in that case, or your supplies that you need on a daily basis and are vital to your quality of life, that you get them. And you may have to fight, you may have to appeal. There are lots of different iterations, which Jeff, following me, is going to go into. It's been a journey. The last thing I will talk about is time. Don't underestimate the time it's going to take you to start, to pre-start, to start, and then once you get started, to get everything going into a system. And then if it's a piece of equipment like a wheelchair that needs interim fixes, it's going to go on from there. So from the complexity woman, I'm telling you, it's a complex system. I'm now going to turn it over to Jeff, who will go into more detail. But I wanted to give you the perspective as a quadriplegic living the life of a Medicare enrollee. Thanks, Eric.
Thank you for that, Sheri. And I'll just wait a second here for the slides to come back up. Well, while that's happening, I'm Eric Krupa. I'm a supervising attorney here at the Center for Medicare Advocacy. So I'm going to go through in a little more detail what's considered durable medical equipment for Medicare purposes, how to obtain that medical equipment, and then troubleshooting. So there are too many rules, too many regulations, too much language in the statute to know everything. So hopefully this can be used as and these slides can be referenced later on as a way to issue spot as issues come up as you're going through the process of getting this medical equipment. Like Sheri mentioned, there's no better, more important advocate than yourself. So unfortunately, due to the complexity here, there's going to be some effort and time needed in order to navigate this really complicated process. Your best partner in that is a doctor who you trust, who's able to listen to you, write orders that are specific, like Sheri mentioned, dotting T's or dotting I's, crossing T's, I'm sorry, and then spending time finding a supplier who you trust. That's not always easy, but spending time on the front end before engaging with a supplier is always important to making the process as smooth as possible, especially for equipment that's going to need repairs, eventually replacement. It's really important to spend time on the front end finding a supplier who's going to work for you. So with all that being said, Medicare's DME definition, it's specific. It's in the statute, it's in the regulations, it's in the policy manuals. It's equipment that's durable, which means it can withstand repeated use. That's the language used in the authority, can withstand repeated use. So what's not considered durable for Medicare's definition? That includes things like incontinence pads, ACE bandages, things that are going to be disposable, aren't covered under Medicare's DME benefit. Now, caveat, there are items that are coverable by Medicare, but not coverable under Medicare's DME benefit. So if you're receiving home health services, if you're at a skilled nursing facility, if you're at a hospital, if you're receiving services through another provider, services that are covered by Medicare, there's the potential that you're going to be able to receive an item through that provider. So Medicare's DME benefit isn't the only way to receive medically necessary items for use at your home or elsewhere. So I just wanted to start with that caveat. But for coverage under Medicare's DME benefit, durable, and then there's this new requirement, has an expected life of at least 3 years. So that speaks to durable, right? And this was introduced and it's only effective for items that are classified as durable medical equipment after January 1st of 2012. So relatively new requirement, has a life expectancy of at least 3 years. In addition to that, is primarily and customarily used to serve a medical purpose, explained in a little more detail, generally is not useful to an individual in the absence of an illness or injury. So something that may be helpful in your home, stairway elevator, exercise equipment, dehumidifier, though that's helpful, that helps you address a medical issue, if it can be used for a purpose other than a medical purpose, might not meet Medicare's definition of DME. And then the last is appropriate for use in the home. So if you could go to the next slide, please, I'll talk about this in a little more detail. So a home for Medicare's purpose is a relatively broad definition. Home is a beneficiary's dwelling, apartment, relative's home, home for the aged, assisted living facility, intermediate care facility. The way that it's phrased in the relevant authority is it's essentially an exclusion. It's anything but a hospital or skilled nursing facility. So the statute itself says a home can be really any place other than a hospital or skilled nursing facility. The idea is if you're in a hospital or skilled nursing facility, they are the ones supplying the equipment for you. I actually did just get a question today from somebody asking, what if I'm in a skilled nursing facility? The skilled nursing facility is being covered through Medicaid, so it's not a Medicare benefit that I'm in the skilled nursing facility. Can Medicare pay for a power wheelchair while I'm in the skilled nursing facility? Unfortunately, the answer to that is no. It turns on, if you're in a skilled nursing facility, the fact that you're in a skilled nursing facility rather than which insurer is covering that stay. And then the last thing, if a person is home for part of the month, but in an institution like a hospital or skilled nursing facility outside of the US for part of the month, Medicare will make payment for the entire month. So important to note that. Next slide, please. Coverable DME. So examples of DME, I listed some things that are not considered DME, but some classic examples of DME: hospital beds, manual wheelchairs, power mobility devices, hemodialysis equipment, respirators, CPAP devices, oxygen equipment and accessories, nebulizers and nebulizer medication, blood sugar monitors and test strips, infusion pumps and supplies, speech generating devices. These are all examples of DME. In this list, you may have noticed, well, some of that is disposable, right? The test strips, the nebulizer medication. Payment may be made for supplies that are necessary for the effective use of equipment. So if you have a nebulizer, but you don't have the medication, the nebulizer isn't going to do you much good. If you have your blood sugar monitor, but not your test strips, the blood sugar monitor isn't going to do you much good. And so Medicare will cover supplies that are necessary for the functioning of that DME. Specific questions about whether something is DME. Really, there's not a lot of guessing about whether a specific item is DME because there are all of these national coverage decisions. So I have a link here. A national coverage decision is a decision that applies nationally as to whether a specific item, so whether that's the hospital bed example, manual wheelchair example, whether that's considered DME for Medicare purposes. If you ever have a question about a specific item, consult the national coverage database linked here. If it's not listed there, so if there's not a favorable or unfavorable national coverage decision, then you may have to be referencing this criteria that I just discussed. Next slide, please. All right, so this is always a big question because there's really a distinction in obtaining coverage if you have Medicare Advantage instead of traditional Medicare. So DME traditionally covered under Part B. So it's not under the Part A hospital benefit, it's under the Part B or colloquial outpatient benefit. Medicare Advantage plans are required to cover all medically necessary services and equipment that traditional Medicare covers. So if an item is covered under traditional Medicare in these national coverage determinations, it has to be covered by your Medicare Advantage plan. However, there could be extra steps to actually obtaining the equipment if you're in a Medicare Advantage plan. What that might look like is, if you're in a Medicare Advantage plan, you might have a limited network of suppliers. So not every Medicare enrolled supplier would be available to you if you're in a Medicare Advantage plan, only in-network suppliers. So you might have to do a little bit more looking. Your search might be a little more limited if you're in a Medicare Advantage plan. In addition, prior authorization is often a factor. Prior authorization is required for a limited number of items, mostly power wheelchairs in traditional Medicare. In Medicare Advantage, prior authorization is really the standard. So before going to your supplier, having your supplier bill Medicare, you're going to have to, or your doctor's going to have to submit a request to your Medicare Advantage plan to try to get prior approval of an item before you even go to a supplier and seek to obtain a specific item. Next slide, please. Okay, so I know Sheri really spoke about this in good detail and with some facts specific to what she's experienced. And so I don't want to repeat too much of what she said. But your treating provider is required to order the DME. So depending on the circumstances, there are different requirements here, right? There might be the prior authorization requirement, certificate of medical necessity might be required, and there might be a face-to-face meeting required. Knowing whether any of this is required, your doctor should know that. But there are ways to research it. CMS does have a list of items that require a face-to-face meeting. They do have a list of items that require prior authorization if you're in traditional Medicare. And then if you want to know if an item requires prior authorization in a Medicare Advantage plan, it probably does. But you can consult your specific plan documents in that case. So you have your order from your treating provider. What do you do next? Hopefully, your treating provider can help you find a supplier. They know suppliers that have worked with previous clients, and hopefully they know a supplier who's going to actually be able to help you and won't be more of a hindrance. But if the search comes, if you need to search on your own, there's this list here, or there's this search engine that I've linked on Medicare.gov. I did see something about the links not working in the slides. Hopefully we can fix that behind the scenes. Any of this is Googleable. I hate to say that in this presentation, but if you Google durable medical equipment cost compare, it's going to be the first link that pops up. So if there's any trouble with the links here, know that this information is readily available with a quick Google search. So you can search for a supplier here, but don't stop there in finding a supplier. You want to call the supplier first and get a feel for them, get a feel for how they operate before electing to go with them for a certain item of durable medical equipment. Once you have the supplier, they should be delivering, setting up, and training you on any equipment. That is part of what they're paid by Medicaid for. So that should be included and should be no extra cost to you. Next slide, please. So again, well, types of suppliers. So not all suppliers are equal. Again, there are networks if you're in a Medicare Advantage plan. And then with traditional Medicare, there are participating, non-participating, and not enrolled suppliers. You're going to want to ask this before selecting a supplier for your item of durable medical equipment. Participating suppliers must accept Medicare allowed charge as full payment, so they can't charge you above the Medicare rate. Non-participating providers may charge above the Medicare rate. In fact, they can charge you the full cost of the item. There's no limit on what they can charge you above the Medicare rate. But part of that conversation you have with them could be, for this case, for my circumstances, will you accept assignment for this specific item in my case? So if they're non-participating, you should always be asking that question. And then if a supplier is not enrolled or if they're out of network, no Medicare payment will be made to the supplier or to you retroactively. Next slide, please. Renting versus owning. A Medicare enrolled supplier should know when Medicare will purchase or rent for you. So talk with your supplier about whether it's better to rent or own the item. Medicare Authority does say that it's up to you to decide whether to rent or purchase, but they retain, Medicare retains, your Medicare Advantage plan retains the right to decide whether to pay in a lump sum upfront or whether to make installment payments. Typically, if you're renting an item, there's a 13-month rental program, and thereafter ownership transfers to you. So there's usually monthly payments for a time-limited 13 months. Medicare will purchase inexpensive items typically, and then customized items specific to you. And then if rented, Medicare makes the monthly payments, and the supplier will pick up the equipment when it requires repairs or is no longer needed. So that's part of what you should be expecting if you're renting a piece of equipment from a supplier. Next slide, please. Repairs, maintenance, and replacement. If an item is owned, Medicare covers the cost to make the equipment serviceable unless it is under manufacturer or supplier warranty. So if owned, Medicare covers. If rented, the supplier is responsible for repairs at no additional cost. This could be a point of contention between you and the supplier, obviously. So again, it's good to ask these questions before engaging with the supplier. Ask them what the process is if you need repairs of an item. Costs of repair for items obtained before becoming Medicare enrolled should be included. So somebody in Sheri's situation who became enrolled after using a piece of durable medical equipment, if you're using the same piece of durable medical equipment through that transition, Medicare should be paying the cost of repairs after you become Medicare enrolled for a previously purchased item. While repairs are underway, Medicare does cover temporary replacement. There should be no requirement for a new doctor's order or certificate of medical necessity for this. Maintenance required by authorized technician is covered, but routine testing and cleaning is not. So you should be expecting to do some of that or paying for the cost of some of that on your own. And then replacement is the exception, and it's possible if there's irreparable damage to the item. That's a limited number of circumstances. And after what's called a reasonable useful lifetime, that's usually considered no less than 5 years, though it does vary with the specific item. Next slide, please. Costs. I'm just going to go through this quickly because it varies, obviously, depending on the item, depending on whether you're in traditional or Medicare Advantage, and depending on whether you have a Medigap plan if you're in traditional Medicare. Part B, if you're in traditional Medicare, is typically going to cover 80% after your deductible is met. A Medigap plan may help you with that additional 20% of the cost. In Medicare Advantage, it's really impossible to provide any sort of overarching guidance. It's going to depend on your plan. It could be anywhere from 20 to 50% is sort of the standard range. You want to do your research before getting an item, obviously, and then before making a switch in your Medicare Advantage plan if you have an expectation that you're going to be using the plan for certain durable medical equipment. Next slide, please. And finally, just some other considerations. Again, specificity. If you need a specific item, the order from your doctor better say that and better detail why that specific item is needed versus a more generic item. Medicare Advantage denials are appealable. Prior authorization denials, denials of billing by the supplier, those are appealable. So if you're denied, the appeal system in general is severely underutilized. Please don't give up. Request a denial in writing, whether it's a prior authorization or a billing denial. And the writing should include instructions for how to appeal. If you have any questions about the appeals process, the Center for Medicare Advocacy is a resource. Don't hesitate to call us. We're happy to talk with you, particularly if you're in the state of Connecticut. But if you're out of the state of Connecticut, we can provide some general information on navigating the appeals process. And lastly, I would be remiss if I didn't mention the competitive bidding program. That is currently on hold. It's unclear when that might start up again. There are always a lot of questions and concerns because that created some chaos in the context of DME. As of right now, the competitive bidding program is on hold, though, and isn't a consideration if you're getting an item of DME at this time. All right, so with that, I'll be happy to answer some questions later, but I'll turn it over to my colleagues at CMA for a discussion on the home health benefit. Thank you.
Great, thank you so much, Eric. Can everybody hear me? Maybe just in a chat, make sure my audio is working okay. So as they mentioned, great, thank you. My name is Christine Huberty. I'm an attorney at the Center for Medicare Advocacy. We're going to switch gears now and talk about Medicare's home health benefit. So I'm going to provide you with a lot of information about what is allowed under the law, what is required under the law. However, most of what I tell you is not going to be what you actually experience in practice. Unfortunately, that is the case, and those of you that have probably tried to get home health care yourselves have probably run up against a lot of pushback. So first, I'll start with the criteria for becoming eligible for the home health benefit. And then I'll describe what services should be available once a person is qualified. Then I'll hand it over to my colleague Wey-Wey to discuss more about the practical challenges, some resources and citations to refer back to, and just some overall tips for advocacy. So first, there are 3 basic criteria for eligibility for the home health benefit. First and foremost, an individual must be under the care of a physician or an allowed practitioner. So this could be a nurse practitioner, clinical nurse specialist, or a physician's assistant. This physician or allowed practitioner must establish a care plan that provides orders for the services and the frequency of those services. So the physician or the allowed practitioner must actually meet with the individual. They must do an assessment, which is also called the face-to-face encounter, and certify their home health needs. Now, this face-to-face encounter must happen within 90 days prior to the start of home health care or within 30 days after the start of their care. And that care plan must also be reviewed and recertified every 60 days. The second and the third criteria here in these two other boxes, I'm going to take a look at more in detail. But that second criteria is that the individual must be what is considered homebound. We'll define that, give some examples of what that is and what that isn't. And then the third criteria is that the individual must need reasonable and necessary skilled services. And we'll talk more in depth about what those are as well. Next slide. So the homebound requirement. Now, there are 2 different eligibility prongs. First is that the patient must either, because of illness or injury, need the aid of a supportive device, the use of special transportation, or the assistance of another person to leave their residence, or have a condition such that leaving the home is medically contraindicated, which is a fancy way of saying it's harmful to their medical needs. It's not recommended that they leave. The second prong is that there must exist a normal inability to leave home, and leaving home must require what's called a considerable and taxing effort. Now, this does not mean that a person must be bedbound. It also doesn't mean that the person can never leave their home or that they can only leave for medical appointments. See, a patient is still considered to be homebound if the absences from the home are infrequent or for periods of relatively short duration. So some examples could be adult day centers, also religious services. An example, I recently had a client who required a wheelchair and wheelchair accessible van to leave the home. She suffered from extreme respiratory conditions as well as anxiety leaving the home. So she and her dad would a few times per year take a short drive to view the ocean. So this would not disqualify her from meeting this homebound status. Next slide, please. So that third criteria is that the services must be skilled. And that skilled definition means that the skills are so inherently complex that they can only be performed safely or effectively by or under general supervision of a qualified professional. The medical reasonable and necessary criteria is based on the individualized assessment of the patient's condition. So this isn't based on just one condition or a diagnosis. It has to be based on that individual's condition. And that is to treat the patient's illness or injury or to maintain the patient's current condition or prevent or slow further deterioration. And that is a critical piece that we're going to discuss. We're going to hammer home a couple times because it's really crucial for people to remember that there is not a restoration potential is not the deciding factor in determining whether skilled services are needed. There is no improvement standard. We'll talk more about that in detail, but the citations here below, this is from 42 Code of Federal Regulations, section 4009.32, if you need to come back and rely on that. Next slide. So the skilled nursing services also need to be what's called intermittent. And so this is less than daily visits, but at least once every 60 days. If it's less than that, if it's less frequent, then at least has to be predictable and on a recurring basis. Or it can also be considered intermittent if it's daily visits, but only up to 21 days. There can be extensions if you need to go beyond that 21 days, but it still needs to be decided that the care is finite and has a predictable endpoint. It won't continue on forever. And then there's a following exception to this where daily insulin injections, if the individual can't self-inject, and if there's no one else available in the home or any other willing person, then intermittent still would be considered daily insulin injections. It would be an exception to that, and they could still receive that on a daily basis. Next slide. So this slide is illustrating that an individual must need and receive at least one of these skilled services. So that's on the left-hand box. Once you kind of open the door with one of these skilled services, that opens the door to then allow somebody to get necessary dependent services. So you have to cover the hurdle here of this first box in order to get any of those dependent services at a later time. And so those skilled services could be intermittent skilled nursing services that I just talked about. It could be physical therapy, speech language pathology or speech therapy, or continuing occupational therapy. So if you're receiving one of those services, then you can also then receive dependent services. So those could be home health aides, medical social services, or medical supplies. Next slide. So home health aid services, these can be really critical for helping people stay in their homes. Those services are defined as hands-on personal care, and they're distinguished from homemaker services, which by themselves alone are not covered. Those are only covered if they are incident to hands-on personal care. So home health aid services can include things like bathing, dressing, grooming, changing bed linens for incontinent patients, feeding, catheter or colostomy care, bed mobility, transfers, ambulation, medication assistance, and simple wound dressing changes. And this is different from the homemaker services, things like shopping or cleaning. Now, it's important to note that under the Medicare home health benefit, this type of care, custodial care, is a covered service. This is different from, say, a skilled nursing facility where custodial care is excluded, but it is a statutorily defined covered service, and the authority for that is at the bottom of that slide. Next slide. So, home health aides, how much can be covered? What does the law say? So combined with skilled nursing, home health aid services can be covered up to 28 hours and any number of days per week, as long as it's provided less than 8 hours each day. And this is subject to review and can vary on a case-by-case basis. Coverage may actually be available for up to 35 hours per week in some cases. Next slide. So I mentioned we were going to hammer this home. Medicare home health coverage, the law is that it is not just a post-acute care benefit. Coverage is available for necessary care to maintain or slow an individual's condition, not just to improve. And so it's not just the law, it's been everyone's been reminded over and over again, first with the Jimmo versus Sebelius settlement in 2013. And then there was a corrective action plan that came out in 2017. This was court ordered and designed to reinforce the fact that Medicare does, in fact, cover skilled nursing and skilled therapy services needed to maintain a patient's function or to prevent or slow decline. Part of that corrective action plan was establishing a whole website dedicated to the Jimmo settlement. And further, in December of 2021, CMS sent a reminder to providers about the Jimmo settlement agreement. So it is still there. It hasn't gone away. Nothing's changed. But I'm sure you still all hear it in your practice and in your experience that and there's still an improvement standard out there. There is not. It's really critical for people with chronic conditions, long-term conditions, that you are not required to improve. You can still get home health services to prevent deterioration or decline, or just to maintain your function. Next slide. And finally, there is no cap on the home health benefit. So it is not temporary. It doesn't expire. There's not a limit. Home health care coverage continues to be available as long as skilled care is needed, and all of those other threshold criteria are still met. So those criteria is 1, 2, and 3. As long as you get through the hurdles of the certification and you continue to meet those different skilled services and you continue to get recertified every 60 days, it can go on as long as you need it and meet the criteria. So then unlimited covered number of covered services. There is no limit. And that's really important for people to know, because I'm sure you will hear in practice that there might be. Some people might say Medicare will only pay X amount of days or X amount of months or something. So I've included the authority for this. So you can look back if you need to point to something and say, no, absolutely not. Medicare says that this can continue. You can look at the Medicare Benefit Policy Manual. That's in Chapter 7, as well as the Code of Federal Regulations below there as well. So with that, I will now turn it over to Wey-Wey to talk more about the real life challenges, what those look like, and what, if anything, that we can do about it. So hand it over to Wey.
Thank you, Christine. Hello, everyone. I'm Wey-Wey Kwok. So yeah, we increasingly hear about Medicare beneficiaries who are struggling to access covered home care, even though they qualify for it. So yeah, these are people who meet the criteria Christine just discussed, but they can't find a provider that will take them on as a client or furnish the amount of services they need for the length of time they need them. And there are a combination of factors contributing to this problem. One is that, providers sometimes misunderstand the law. For instance, some providers still insist that being able to independently operate a wheelchair outside of the home or, attending an adult daycare program disqualifies someone from being considered homebound, even though Medicare policy expressly refutes that. Now, these types of misconceptions sometimes stem from erroneous information and claim denials that these providers have gotten from Medicare's own contractors. And then, this is perpetuated by the fact that, providers use this information about Medicare, misinformation about Medicare coverage, as a way of denying and limiting care. The home health payment structure and quality rating system are also factors in the problem. Because Medicare's policies on reimbursement, quality measures, and audits incentivize providing home care to post-acute patients who may only need short-term care and who are expected to improve fairly quickly. Because of this, from a business standpoint, providers may find it more advantageous and less risky to serve patients who fit that profile. And this has been detrimental to patients who are referred from the community, who may have longer-term chronic conditions that may not improve significantly. And we also know that widespread staffing shortages are also a factor affecting access. And home health providers have no obligation to take on a patient if they can't, if they don't have the staff to provide all the services that the patient needs. As a corollary to that, Medicare cannot require agencies to accept someone as a client, even if the person meets the coverage criteria. Now, that being said, agencies may not refuse care to someone based on their Medicare status. So, for example, it would be okay for a provider to say to a Medicare patient after evaluating them, we can't serve someone with your significant needs. But it would not be okay if that same provider is accepting other patients with the same condition and needs who happen to have a different insurance or who are privately paying. Next slide, please. So by regulation, agencies must agree to meet certain conditions in order to participate in Medicare. I'll highlight a few of the obligations that providers have when they take on a Medicare client. So they're supposed to involve clients in care planning, which means communicating with the patients and their chosen representatives and caregivers in establishing and revising the plan of care. They also have to identify who the caregivers are and determine if they're actually willing, able, and available to assist with care. They can't just assume that the person has a caregiver. They also have to communicate with and integrate orders from all of the client's physicians to assure coordination of services. Next slide, please. So the conditions of participation also address how discharges and transfers should be handled. Discharge is only appropriate when the patient's physician and the home health agency both agree that the patient has achieved the outcomes and goals established in the plan of care and no longer needs skilled services. And here I highlight again that the goal of care can be maintenance. Additionally, it is a home health agency's responsibility to arrange a safe and appropriate transfer to another agency if the patient's needs exceed this agency's own capabilities. So they can't simply discharge a patient who still needs care. Next slide, please. So we've seen that advocacy can sometimes open doors to home health coverage and care. We do advise people who are seeking home care to really actively participate in the home health agency's assessment, that initial assessment, and also any subsequent recertification assessments. They should express their health issues and needs and make sure that the orders clearly document the skilled and unskilled needs and goals for home health care. We advise them to consult with their doctor or practitioner who will be certifying and signing the plan of care. Their doctor's office can be an important advocate to help explain and document why clinically they might need a certain type or amount of care when the agency is trying to give them less than that. And the orders in the plan of care should document in detail the skilled needs and goals. And if the original goal was improvement or restoration, restorative therapy, but that has changed to needing maintenance nursing or therapy, then it's important to get a new order signed by the physician clarifying why skilled care is now needed to maintain, deter, or slow decline of the patient's condition or function. Next slide, please. Now, if someone is enrolled in a Medicare Advantage plan, we advise them to contact all of the home health providers, or as many as they can, that are in their plan's network to determine which one can best serve their needs. The law requires Medicare Advantage plans to provide at least as much coverage that people enrolled in traditional Medicare get. We know in practice, though, that many Medicare Advantage plans do not honor that. Some might only approve 3 weeks of home care or only authorize the skilled service, but not the dependent services that the patient needs. Providers are sometimes reluctant to take on a patient who is higher acuity, meaning someone who might need a greater volume of skilled or dependent services. And we counsel such individuals to ask the agencies whether they bill for outliers, which is reimbursement on top of the bundled payment to furnish additional visits to someone who needs more care. So presently, outlier payments are allowed to constitute up to 10% of a provider's total annual fee-for-service payments. Now, as a last resort, we sometimes advise people to accept less services than they qualify for. And the thinking here is that some care might be better than none at all, and it might offer some chance in the future they could get more services with that agency. Next slide, please. So I want to talk a little bit about appeals. A beneficiary who is getting home health services may request an expedited or a fast appeal if their provider plans to terminate all Medicare covered care that they're receiving. Note, though, they're not entitled to a fast appeal if the agency is just reducing care or terminating one of their services. Providers are required to issue beneficiaries a notice of Medicare non-coverage, or a NOM-NOC, at least 2 calendar days before services end, or on the second to last home visit. Now, by following the instructions on the NOM-NOC, the beneficiary can appeal to try to keep the covered services in place. And they have to request an expedited determination by the qualified improvement organization no later than, or the QIO, no later than noon of the day before the effective non-coverage date. The provider then has to give them a written, detailed explanation of why they think the care is no longer covered, including any policy or guidelines they relied on. Now, the QIO is supposed to review the evidence, obtain input from the patient and provider, and then issue a decision within 72 hours. If the patient is dissatisfied with the decision, they can request an expedited fast track reconsideration. Next slide, please. So there is also a standard or regular appeals process, which starts on a slower, longer time frame. Now, some beneficiaries may be able to use this appeal if their provider believes that Medicare won't cover or will no longer cover items and services, either because they think the patient's not, that the services aren't medically necessary, or that they're custodial, or that the patient is not homebound. The provider must give the beneficiary an advanced beneficiary notice, or an ABN, informing them of expected non-coverage. Now, this notice effectively shifts liability onto the beneficiary for those services. And the ABN is only required if the person wants and is willing to accept liability for the services. Now, in order to initiate the appeals process, the beneficiary has to ask the provider to submit a bill to Medicare for the services they received. And, providers are required to submit a claim upon request. And this allows the patient to get an official decision from Medicare that they can then appeal. Now, I want to clarify again that with standard appeals, you are appealing to obtain coverage and payment for services that were already provided. And for these appeals, it's important to obtain thorough documentation of the services, like the evaluations, progress notes, because if a visit is not documented, then, it didn't happen. So, okay, next slide, please. Now, if you are appealing a denial, you should know that Medicare's contractors and administrative reviewers do not have discretion to ignore the mandates and criteria established under the statute, the regulations, and policy. So on this slide, there are citations to the relevant legal authorities governing home health coverage. This Medicare Act is the overarching authority. Then there are also regulations promulgated by the agency. And then the agency has also issued more detailed policy guidance to home health agencies contained in the Medicare Benefits Policy Manual. So referencing these authorities can be helpful if you're appealing or trying to get care. Next slide, please. Now, when someone is seeking a provider, we encourage them to visit Medicare's website. By using the Care Compare tool at medicare.gov, they can get a list of the Medicare certified agencies that serve their zip code. And we tell people not to focus solely on agencies that have 5 stars, because the star rating system is not always reliable, as it's based on quality measures that favor patient improvement. So it's entirely possible that an agency is getting 3 or 4 star rating because they're serving more patients who are not able to improve. We also suggest looking at the official Medicare and home health care booklet. It's an official publication. It's not a perfect resource, but it does give consumers basic information about what's covered and the criteria, and also helpful tips if they're choosing a home health provider. Next slide, please. And finally, the Center for Medicare Advocacy's website also has numerous resources for beneficiaries and advocates concerning home health coverage, including information about the JIMO settlement and toolkits and self-help packets. And that's all I have. And I'm wondering if we have time for questions and discussion.
Hi there. Sorry about that. I was on mute. This is Matt again. And I know we are a little bit over time. I would not, demand that our Reeve co-hosts stay on with us, but I will demand that the center co-hosts stay on with us because we have so many questions. And we still have over 600 people online, and thank you for that. Absolutely amazing turnout. Um, Eric and anyone who wants to jump in, we had a couple of themes going on DME. People are, I won't say confused, but wonder about the use in the home phrase. As Dawn said, are disabled people supposed to be homebound all the time?
No, doesn't have to be used exclusively in the home. So can be used outside of the home, but primarily for use in the home. So that's an important distinction, and thanks for raising that. So a power wheelchair, obviously you're going to be using that in the home and then outside of the home. I think that's the perfect example of an item that is used primarily in the home because you're primarily at your home, but can also be used outside of home. I think the distinction would be an item exclusively for use outside of the home. So something like an item to help you get in and out of your vehicle, that would not meet that definition.
All right, thank you. And the second thing was nursing homes. So, for example, Joan asked, so Medicare would pay for a power wheelchair or scooter, but not in a nursing home? Nursing home and DME is an issue.
Unfortunately, yes. If you're in a skilled nursing facility that doesn't meet the definition of home, that's specifically excluded under the statute. And so you wouldn't be able to get the item covered under Medicare Part B. It's possible, I haven't heard of this happening, but possible that a Medicare Advantage plan may still decide to cover because they can have a more expansive definition than traditional Medicare. You should be working with the skilled nursing facility to make sure that you have the means to get around the facility. They should be providing you with the necessary equipment to navigate the facility, obviously. But it wouldn't be covered under Medicare's traditional Part B DME benefit.
Thank you. And you actually lead into another common theme of questions. We talk about all of these coverage rules and options, and we get multiple questions every time we do one of these. For example, the JIMO settlement that was discussed by Wey and Christine, does that apply to Medicare Advantage as well as traditional Medicare? Do all these coverage rules in DME apply to Medicare Advantage plans as well as traditional Medicare?
For DME, yes. Yeah, the answer is yes. You shouldn't be being denied coverage in Medicare Advantage if it would be covered in traditional Medicare. And I'll let either Wey-Wey or Christine speak to home health.
Yeah,
Well,
same. Oh, go ahead, Wei.
Go ahead, Christine.
I was just going to say, yes, the JIMO settlement standard applies to Medicare Advantage plans as well. So Medicare Advantage plans can, do different things with prior authorizations and other types of creative ways to save money, but the improvement standard is the law and they have to apply it in the same way.
Thank you. Perfect. We had several people asking about prior authorization, and very specifically, who gives the authorization?
In the context of DME, it
Yeah.
would be your Medicare Advantage plan. So your doctor would be sending the application essentially to the Medicare Advantage plan, and they'd be issuing a decision that is appealable. In Medicare, traditional Medicare, it's federal government making the decision.
All right. We've had several thematic questions for home health too, and I bet you can guess what some of the big themes are. For example, center friend Lynn says, I've had multiple home health agencies assessments override my doctor's orders, and then they discharge me. What can I do?
Maybe Wey can speak to the appeals, right?
Right. So if, again, we have the appeals ability on the end where you're already getting care, then you have a right to the standard appeal. But unfortunately, as I mentioned, those standard appeals only work if you receive the services. So you have to be willing to accept liability for the services and then bill for those services after they're already provided. And not everybody, can take that liability on, with the hopes that it'll get covered on appeal. Um, and yes, Lynn, we hear about that a lot, that the doctor wants to order X, Y, Z, and the agency only wants to give X. And unfortunately, there's not always a good, there, there's not always a way to get past that conflict there, because ultimately it's the agency deciding, what they are willing or able to provide. So if the patient really, really cannot do safely without what the doctor believes that they need, then, technically the home health agency should not be providing service, caring for that patient at all. So it's a tough one because, as I mentioned, it is, although, the doctor is signing the orders, really, we know that it's the home health agency that's kind of dictating what is in those orders.
Thank you, I guess.
I know, I know.
Another theme we had was custodial care that was mentioned during our presentation. Sharon asked if you could please talk more about when custodial care is covered and what kind of things are covered. As you might imagine, that's probably pretty important for our audience here today.
Yeah, so custodial care are those things that don't have to be done by a skilled person directly, kind of like CNA type services. And so those are, in terms of the home health benefit, those services are covered under those. So those are things that I mentioned, like what a home health aide would do: bathing, dressing, grooming, feeding, catheter care, that kind of stuff.
All right, thank you very much. And I'm going to answer a couple questions. Slides went out this morning and will go again in a follow-up email. They were also posted in the chat. I will try to collate the chat and maybe the Q&A if I can figure out how to do that and get links to those. And yes, we are recording and we'll also send a link to that recording once it is processed because we got a lot of questions on those topics.
Can I go back for a moment?
Yes, absolutely.
Regarding the custodial care and what aides provide, that's another area where we see a lot of misinformation from home health providers saying, that Medicare only covers a bath aid once a week, so, things like that, that, people really need to push back on, because as, Christine mentioned, home health aid services can encompass much more than just a bath once a week.
Right, and everybody on this call knows the value of ongoing home health aid services. Lynn again brought up an issue. Is there any stick to make home health agencies actually provide services? And you mentioned that didn't CMA have a lawsuit?
Well, yeah, I mean, the stick comes in the form of if you're able to appeal and get coverage for it, and then really, you know, publicize that, that this is covered by Medicare, it will be paid for, but I think there's, as I mentioned, there's just so many factors at play here. It's like the amount that they're getting paid, the providers are getting paid. So I think a lot has to change for policy wise as far as like payment and other incentives that Medicare provides to home health agencies to, really encourage them to provide care to people with chronic conditions.
Thanks, Way. So it sounds like call your Congress people.
Yeah,
Let's see if we can get a real Medicare home health benefit.
right, right. And enforcement, too.
All right. I'd like to pull Angel back up for just a moment, because we want to see that QR code. Um, Hi, Angel.
Hi, how are you? Thank you so much. It might be hard to go back to my earlier slides, so just as a reminder, I put in the chat a link to the ways to take action to support the Paralysis Resource Center. And it also, I believe, will be in the follow-up materials. So
Absolutely.
thank you.
All right. Thank you all, and thanks for the 500 people that stayed on overtime with us. Really fantastic. Thanks to our awesome presenters and to the Christopher and Dana Reeve Foundation for their support of today's presentation. Please do make sure that when you get our follow-up email, you click the link and take action to preserve the only national resource dedicated to supporting people living with paralysis. It's amazing that it could possibly be on the chopping block. So please act now, and we really appreciate it. Thank you all again, and I will now conclude today's presentation.